السلام عليكم. مال عبد الله.
السلام عليكم.
سامعني كويس؟
اي سامعك كويس، ممتاز جدا.
طيب كيف اقدر اخليك تسوي شير سكرين؟ انت قادر تسوي شير سكرين الحين؟
اي اتوقع اقدر اسوي. لا مكتوب host disabled participant screen sharing.
طيب ميك كو هوست يلا. والحين
الحين اي كان شير ناو.
طيب خلاص اكسلنت. طيب اذا بقى
تسوي شير من الحين ولا؟
خلها مفتوحة وجاهزة عشان ما نطول ان شاء الله.
طيب.
شو اخبارك طيب؟
والله الحمد لله تمام.
كيف الامير محمد؟
رجع انزحم عقب ما فتحوا الاي ار قبل 3 اسابيع تقريبا او 4 اسابيع.
ايه لازم خلاص ما عاد لان تروما كاثرة مرة ما شاء الله.
مره مو شوي.
بس هل رجعت الريسورسز ولا بعدها؟
مو كلها، في اشياء موجوده في اشياء لسه.
الله يعين والله.
امين يا رب، رحمك الله.
دينا وديكم الله. طيب I'll start admitting everyone ها.
تمام.
طارق is joining ان شاء الله.
ايوه جاي. ارسلت له قبل شوي يقول يلا الحين بيدخل.
طيب, I guess we can start. السلام عليكم ورحمة الله وبركاته. Good evening everyone. Thank you for attending our monthly trauma and critical care meeting. Tonight we're going to be discussing two very interesting cases from two major different trauma centers. As we are all seeing now, trauma is getting busy again with the reopening, and we're starting to seeing more and more interesting and complicated case. And it'd be nice to discuss two similar yet different cases that presented to two major centers where our colleagues and friends are working, and it'll be interesting to hear and listen from them and to discuss these good cases. And I want to actually start with the first trauma presentation. This is coming to us from the Trauma Center, Prince Mohammed bin Abdulaziz Hospital. It's going to be presented by our senior fellow and assistant consultant, Dr. Abdullah Al-Bdah, who is my friend and my fellow, and as an esteemed trauma surgeon, inshallah, who's going to be presenting about blunt cerebrovascular injury due to traumatic mandibular fracture. The case is supervised by Dr. Tariq Al-Sabbahi, who is a trauma and general surgery consultant at Prince Mohammed bin Abdulaziz Hospital, and is a very close friend of mine. Without further ado, Dr. Abdullah, please, the floor is yours. I'm excited to listen to this interesting case.
Assalamu alaikum. Thank you so much, Dr. Ahmed, for the nice presentation. My name is Abdullah Al-Bdah. I'm trauma and acute care surgery fellow, King Saud University, assistant consultant general surgery, Prince Mohammed bin Abdulaziz. Thank you so much, Dr. Tariq Sabahi. He's my consultant, trauma consultant, and the head of the trauma surgery unit in Prince Mohammed Abdulaziz Hospital. Actually, he was the consultant on call during this interesting case, and he was the MRB for this case. So today, our case, I'm going to talk about blunt cerebrovascular injury guidelines. But our case that presented to us, it was injury at the zone 3 due to a traumatic mandibular fracture. Thank you so much for the Surgical Critical Care Society for the surgical chapter to accommodate us today. Okay, at the beginning, we will talk about a small introduction about the blunt cerebrovascular injury. Then we will go for a little refreshment of the anatomy of the neck, especially the vessels and the vessel map in the neck. Then we will talk about our case. We will present our case and all the dilemma that's happened during that case. Then we will go through the guidelines from the East, guidelines for the blunt cerebrovascular injury. So at the beginning, blunt neck trauma is common, but significantly injury is relatively uncommon, which is considered as 1 to 3% only. The unrestrained driver hitting a steering wheel or direct blow to the neck are two common mechanisms. Violent torsion, flexion, or extension of the neck also may result in blunt neck injury without external signs of trauma. Often the sign and symptom of blunt neck trauma are subtle. Okay, starting just to refresh everybody about the zone of the neck, starting with zone 1 from the sternal notch to the cricoid cartilage, from the cricoid to the angle of the mandible, zone 2, from the angle of the mandible to the base of the skull, zone 3. The vessels, the major vessels going to the brain and to the circulation up to the brain, it's basically 4 vessels. We have the 2 vertebral arteries, and we have the 2 internal carotid arteries. The internal carotid artery, where is our injury happened for this case we are presenting tonight. Usually it's giving the anterior cerebral artery and the middle cerebral artery and the posterior communication artery. Okay, so starting with our case, we have a 22 years old male brought by EMS to our hospital as he was found in the street screaming alone. EMS reported history of MVC, rare impaction as it appeared to them, reported to be vitally within normal range, no further details given. Patient was in our emergency department with a clear facial trauma. Patient was agitated, moaning, no further information obtained from him due to the current condition of the patient. He didn't answer anything and didn't seem to be a comprehend, and there was no reaction upon the attempts of the history taking. And due to the difficulty of the injury or severity of the injury, especially with the severe fracture in the mandibular bone, it was open fracture and there was blood coming from his mouth as well. The emergency consultant, he elected to intubate the patient. So the patient basically intubated for his primary survey. He was intubated in C collar. There was equal chest rise with equal bilateral air entry. Hemodynamically, he was stable. Two large deep wounds over the chin without active bleeding, only minimal oozing, so the gauze applied. EFAST was negative. Pupil are within normal diameter, equal reactive bilaterally, as mentioned by our colleague in the emergency upon his presentation. Again, upon the exposure, the only finding, it's only the 2 large wounds in his chin, which was dressed and covered immediately. For the secondary survey, nothing nothing was unusual. The chest X-ray and pelvis X-ray revealed normal chest and normal pelvis with no fracture or pneumothorax or anything. So we decided to shift the patient to the CT scan. The plan, this patient need to have a trauma CT plus CTF of the neck due to the severe facial injury, severe mandibular fracture. At the radiology department, unfortunately, while the patient on the CT table, the injector stopped working. So we did for him the CT scan with a manual injection of the contrast. And during that time, we start to notice a hematoma at the angle of the mandible bone, which was not present previously. And just to make it clear here, during the secondary survey, there was the primary survey, secondary survey, even the consultant of the emergency, he mentioned that while he's intubating the patient, he didn't notice this hematoma. So we just noticed it on the CT table. So we observed it for like quite a bit of time, and it wasn't expandable at all. If you can see in this picture, this is the hematoma exactly at the angle of the mandible. This is the best photo that I found. And you can see here the deep two wounds, which is appeared that the mandibular fracture. So after the CT scan, we decide to go for a conventional angiography, for neck angiography diagnostic, and if there is any bleeder to stop that bleeder. The trauma CT result came back as no injury at all in terms of the brain, chest, abdomen, pelvis. The only injuries it was at the mandible area and in the neck. They found displaced comminuted fracture are involving the midline and left side of mandibular body. Also bilateral displaced fracture are noted at both mandibular condyles. Fracture of the left conoid process is also seen. The study it was suboptimal, as we mentioned, due to lack of the contrast injector, so it was done by manual injection. The lower part of the left internal jugular vein is slit-like with no obvious obfuscation, noted at its distal part, proximal at the jugular foramen. Also, the distal segment of extracranial left internal carotid artery is significantly attenuated with faint opacification, which is raised the possibility of vascular injury or thrombosis. And they are recommending for the angiography. There was a significant soft tissue swelling of the left side of the lower neck, can be suggestive of soft tissue hematoma. Few hyperdense areas are noted, could be areas of extravasation. So as you can see here, the devastating fracture in the mandible in these two 3D pictures. In the after the patient shifted to the angio suite for the diagnostic angiography, the neurointerventionist was there already, and he started the procedure. And the finding was no clear extravasation in the major vessels, but the result came as there is left internal carotid dissection with a pseudoaneurysm immediately after the bifurcation. Is the video working?
Yes, it's working.
Okay, so as we can see here, specifically here at the area of the bifurcation, the pseudoaneurysm and the dissection at this segment just prior to the cranial part, it's in the cervical part. So there was like a small meeting in between the trauma consultant, trauma surgery consultant, the neuro interventionist, and the maxillofacial surgeon about the option of management for this patient. maxillofacial consultant, he was telling that this patient needs to go for urgent surgical intervention from their side for irrigation and debridement and closing the open wound, with the delaying of the definitive management around for the next 6 months, because most likely he's gonna need like a fibula implantation, and he might require a higher center than our center. So since the patient is going to the surgery, and there's all the discussion about either to go immediately to stent this pseudoaneurysm or no, the decision was at the end to go without stenting the pseudoaneurysm and going for directly maxillofacial surgery. So they shipped him to the OR and they did their irrigation and debridement and they closed the wound. Then after that, the patient shifted to the ICU, where he started on IV heparin and aspirin immediately. First day after admission, all of this done for the patient while he is in stable condition in terms of normal blood pressure, normal heart rate. He didn't require a lot of blood transfusion. He just received only maybe 1 unit of packed RBCs in the emergency room. Other than that, he didn't require any blood transfusion after that. He never ever been on pressor or any anaerobic support. The first day after the admission, the patient underwent a CTA and MRI with MRA, which came as there is a pseudoaneurysm which arises from the posterior aspect of the cervical segment of the internal carotid artery. It's measuring about 0.9 by 0.7 centimeter, with neck measuring about 0.6 in diameter. Distal to the aneurysm, the internal carotid showing stenotic segment spanning about 1.5 centimeter, which was considered more than 25% of the diameter of the vessel. Otherwise, all scanned arteries are patent. No obvious dissection can be detected. Incidental finding: the right anterior cerebral artery supplied from the left anterior cerebral artery. If you can see in this picture, here is the area of the injury, and we can see the filling again, came back again to the internal carotid after passing the skull bone. During doing the MRI and MRA brain for the patient, there was large acute infarction, unfortunately, in the territory of left middle cerebral artery, including the frontal lobe, frontal operculum, insula, quadrate, and both basal ganglia, with multiple small infarction foci in the left partial and occipital lobe. There is a small acute infarction seen in the territory of the left anterior cerebral artery involving the middle side of the left frontal lobe. There are at least 2 small infarction foci as well seen in the right frontal lobe in the cortical watershed area. There is loss of normal signal void of the visualized part of the visualized part of the extracranial segment of the left internal carotid artery, with a partially visualized pseudoaneurysm at the distal part of the cervical segment of the vessel. The petrous and cavernous segment of the left internal carotid artery are not visualized and likely near totally occluded. The left middle cerebral artery and anterior cerebral artery are attenuated with paucity of the cortical branches. The left posterior communicating artery is relatively large in size. As we can see here, unfortunately, he developed a stroke. And we can see here, it's disappeared totally, the left internal carotid artery, because of the stenosis and the pseudoaneurysm, with the difference of the timing of the velocity of the contrast. It shows here like if it's occluded, but it was only stenosed when we are, as we saw in the conventional angio, which was done 24 hours ago to this picture. Okay, so during the first day after admission, after again a discussion about the option of the management for the maxillofacial surgeon, we agreed that this patient needed to go for a tracheostomy due to instability of the fracture. And the neurological exam revealed right upper limb weakness, grade 2. So then after that, the patient kept on sedation and mechanical ventilation. The first week went smoothly without any further complication. At day 7, the CT angiography repeated, which was compared to the previous one, and start to show interval increase in size for that pseudoaneurysm, which is now measure 1.6 by 1.8 centimeter, associated with increased stenosis of the internal carotid artery luminal, adjunct to the site of the pseudoaneurysm. The distal segment of vessel as well as the intracranial artery show no significant interval change. As we can see here, it's getting big in size. This is the pseudoaneurysm, and this is what's remaining from the lumen for the flow, this small part. And we can see here as well, this is the pseudoaneurysm, and here only the remnant of the vessel. On day 14, the conventional angio repeated by our neurointerventionist, Dr. Ali, which showed totally occluded left common carotid and left internal carotid artery. As we can see here in this video, it's totally occluded at the level of the bifurcation. The left vertebral artery injected, and it's showing a good filling to the left anterior circulation through left posterior communication artery. As we can see here, we can see the good refilling of the anterior circulation through the left posterior communication artery, which giving us, as per Dr. Ali, it's giving us a good prognosis, inshallah, for the patient. So about the left internal carotid, it was occluded, and there was no need to do any further intervention for it. So in the regards of our patient, he is still in the ICU admitted, and they are weaning him now from the sedation, and the GCS start to improve. As we mentioned, he's having only weakness in his right upper limb, with a good neurological exam for his for his right lower limb. The maxillofacial, they are planning to take him for definitive intervention, maybe in 6 to 9 months period. So for the guidelines, we are going to talk about the evaluation and management of blunt cerebral.
Dr. Abdullah, thank you very much for presenting this case. It's very interesting. So there, I just wanted to hear maybe if Dr. Tariq has anything further to add to the case, and I would like to ask the audience to raise hands if they have any question, and maybe after the comments of Dr. Tariq, we can go over the guidelines, and then we can ask the questions that need to be asked. Dr. Tariq.
Okay, sure.
Assalamu alaikum. Thank you very much, guys, for the opportunity. Unfortunately, this case is we presented because it's a very devastating injury in the mandible, and it's taking the internal carotid, as you see in the presentations. The only dilemma that we have that time that shall we stent the patients The problem with the stenting, you know, that it has weak evidence in internal carotid injuries. The other problems is when we put stent, you have to load the patient with heparin and antiplatelets. The other dilemma is we will take him immediately for surgery for the mandible fractures for the wound, so it will cause another bleedings. And in this case, as you know, the stroke for internal carotid artery is about 30% in the initial presentations. Patient was intubated, so we cannot evaluate the neurological deficit. So we don't know if he has stroke already or not, but obviously that he has at the beginning. So the stent was out of debate at that time, so we elected to take him for debriding the wounds and close the surgical site, and for reconstructing the mandible later on, and we did tracheostomies. The stenting was planned after like 7 days. We were planning to stent him for pseudoaneurysm, but unfortunately it was totally occluded. Now, if you will stent him again, you know, it will cause hemorrhagic stroke again with this mainly supplied to the brain, because we figured it out that it's the major blood supply to the brain. But fortunately that he has vertebral communications, which minimize the stroke or the stroke later on with the heparinization, of course. I think I invite Dr. Ali Zair also with us if he wants to comment on something. He will add us something. I don't know, Dr. Ali, if he's available.
Yes, Dr. Ali is available. I unmuted him. Dr. Ali, حياك
Dr.
الله.
Ali Zair, he's our department and he's neurointerventions. Welcome, Dr. Ali.
Assalamu alaikum. Good evening, everybody. Thanks for your kind invitation and for this beautiful presentation, Dr. Abdullah and Dr. Tariq. Here, I just want to add something regarding as you both mentioned, the presentation was dissection. Now, in these cases, we know the dissection is a dynamic disease and it's a progressive. Like if we see the patient now and we repeated the images tomorrow after tomorrow, definitely there will be some progression by the meaning of pseudoaneurysm, by the meaning of further distal stenosis. Now, this patient was a kind of dilemma because we know this is a trauma. This is not like a stroke patient. Usually stroke patient, there is more evidence and we can go ahead and stent the artery and start him on dual antiplatelet therapy. And we know that the risk that we have, the hemorrhagic versus thromboembolic is clear. But here in the trauma literature, it's not that well studied. We don't know if we go ahead and stent the artery and start him on dual antiplatelet therapy, how much is the risk? And of course, there will be a need for surgical intervention. Now, if he is on dual antiplatelet therapy, definitely we will not be able to hold any of the antiplatelets. So there will be no possible surgeries in the next 9 months. That was the thing that we were debating initially. Now, luckily, this patient developed natural collaterals, although the left internal carotid artery was the dominant artery, and the right anterior cerebral artery was hypoplastic. So part of the right side, the internal circulation of the brain, was actually fed by this.
Dr. Ali, I think you're muted. If you can unmute yourself again, please.
Hello, can you hear me now?
Yes. تفضل.
Okay, sorry. So, sorry, where did I stop before? What was the last thing you heard from me?
It was muted for only about 10 seconds.
Okay. So I was talking about the way of treatment for dissection. Usually these arteries and in the and the skull base of the brain, so they are not amenable for open surgical treatment, usually treated by intervention. So we have two ways of treatment here, either reconstruction or deconstruction. The best modality of treatment, always bare and visual occlusion, but we cannot go ahead and do that unless we have a baseline that this occlusion of the artery will be safe to be performed. And in order to make that possible, like safely possible, we have to do balloon test occlusion. We have to make sure that the patient is awake and we can communicate with the patient and make sure that the patient is, when we put the balloon and occlude the artery, the collaterals in the brain will take over the occluded vessels and will perfuse the brain nicely. But unfortunately, that was not possible because the patient was intubated, he had stroke, and his level of consciousness was not up to the level that we can really rely on the assessment. The other two things, the neurophysiology monitoring, and it's not really accurate, and the sensitivity and specificity of this test is not the best. So we elected to watch the patient, and on CTA, as you showed, the pseudoaneurysm was progressing. So we decided to take him back to the cath lab and start with the stenting. We started him on dual antiplatelet therapy. And luckily, when we injected the left common carotid artery, the left internal carotid artery was, the pseudoaneurysm was thrombosed and occluded. And that's natural collateral. Like that happened gradually, like not sudden. So the brain started to perform and open the collaterals through the posterior circulation through the left vertebral artery. And when we injected the left vertebral artery, the left BCOM, posterior communicating artery, was perfusing nicely the left anterior circulation of the brain. So that was actually his best option. I mean, this is this is the natural history. Sometimes it's better than our intervention, and that's what happened actually. So now we'll keep the patient only on aspirin and no need for dual antiplatelet therapy. There will be a room for reconstruction for the maxillofacial. They don't need to wait for 6 to 9 months. They can go ahead and take him. They can do the flap on aspirin.
Excellent.
Hello?
Thank you very much, Dr. Ali, for this nice talk, and I commend the team. Actually, since there are some raised hands, maybe we can take a couple of questions now before the guidelines. I'll start with Dr. Ahmed Twajer.
Hello to everyone. I'm very thankful about this interesting case. I have just two questions. The first question is about the method of intubation of the patient. Is it was orotracheal intubation or nasotracheal, as he has a multiple complex injuries in the mandible? The second question, what about the percentage or the estimated risk for rupture of this aneurysm during the surgery, the urgent surgery was done for his maxillofacial injury? Thanks a lot.
يعطيك العافية دكتور أحمد. دكتور طارق or Dr. Abdullah, if you can answer.
For the intubation, it was oropharyngeal intubation. It was difficult and challenging, as mentioned by Dr. Yazid Al-Mutlaq, the consultant of the emergency. He's the one who intubated the patient. And the problem was that his mandible was hanging. Literally, his mandible was hanging, and he was facing multiple difficulties to hold his mandible and intubating him. But he managed to intubate him at the end. And about the risk of the perforation of the aneurysm, or the rupture, sorry, of the aneurysm, the risk is there all the time. Because of that, we were thinking about stenting this aneurysm just for the risk of the rupture.
And the surgery, the one they did maxillofacial, it was only in the wounds. They went through the neck exploration or something that might increase the risk of rupture.
I was actually having the same question. I was wondering if, because there was a hematoma. So technically, when you're exploring the wound and it's a hematoma that was expanding in the CT, I questioned the possibility of maybe uncontaining a possibly contained situation, but I think you guys maybe determined that the level of injury was higher up and it was away from the wound, if I understood correctly.
They did only Ahmed the debridement, the wound, and they didn't explore the mandible formally, like they open the wound or they extend the wound. They just wash it and they close the wound. That's what they did.
Great. Dr. Mohammed Sinani. Allah يحييك محمد.
Allah يعطيك العافية. Thank you so much for this gathering, and thank you so much for this case. Everybody agrees it's a challenging case in many aspects. But I would like to discuss with Dr. Ali regarding the pseudoaneurysm of internal carotid, and especially if it is away from the bifurcation, not accessible for the surgeon. And he thinks that stenting is not well studied and probably not recommended. I can mention that Adams College Shock Trauma Center in Baltimore, Maryland, they are liberal in doing those stents. Yes, it is difficult to do other surgeries if you need dual antiplatelet treatment, but the options are whether to do other surgeries quickly, then to deal with that pseudoaneurysm which is not accessible. This is number one. Or to operate on aspirin. Plexus can be, I think, stopped, and he can correct me. It depends on the product or the whatever the experience with the stent itself. Plexus probably can be stopped. The other option is to operate on aspirin with high risk, whether it is orthopedic surgery or any other surgery. But now, let me make this statement. If it is not well studied, it doesn't mean it is not a good option. This is what I think. And I think, although it is somewhat not a standard, you cannot make a standard, but I can tell you that we have few cases, BCVI with pseudoaneurysm high up, and at the base of skull, not even below the base of skull. And we were successful in stenting both. And as you see in that case, maybe you can say everybody, retrospectively, everybody is smart. Now we have this injury. It is what was not only pseudoaneurysm. We have extension of the thrombosis. This intimal flap kept building up and down thrombosis until we got complete thrombosis. So tell me, what is your take? What is your views? Thank you so much, everyone.
Yes, thanks, Dr. Sinani, for this nice question. Yeah, and in this case, not only the pseudoaneurysm was not the issue here, because when you have dissection in the internal carotid artery, which is perfusing the brain mainly without any branches in the neck, so your main concern is the brain. Now, the incidence of thromboembolic complication is higher than the incidence of hemorrhagic complication. So our main concern was the thromboembolic complications. Now, if we want to go so we were not thinking of the pseudoaneurysm initially when we did the initial angiogram, because there was no distal stenosis to the aneurysm. And the standard care of treatment, if there is no distal stenosis to the dissection in the internal carotid artery, that means the brain is perfusing nicely. We just need to start the patient on dual antiplatelet therapy, and the stent is not the standard treatment. Now, if there is a stenosis distal, like flow limiting stenosis distal to this dissection, that's another dilemma, which was not there. Another thing here is the stroke. Usually when we have dissection, when we have occlusion, when we have stenosis, we always think of the brain. If we have a stroke, we always think about the core of the stroke. Is it big core or small core? Why? Because if it is a big core and we want to stent, we have to start the patient on dual antiplatelet therapy. There is a risk of hemorrhagic transformation. Now, the patient on the MRI, he has a relatively large core stroke. It's not a small stroke. So there is a risk of hemorrhagic transformation. Usually in the carotid stenosis, we have a window of 3 to 14 days. If we have a large core stroke, we tended to elect our stenting toward 10 to 14 days. If we don't have stroke and we have stenosis, symptomatic stenosis, usually we do what we call it hyperacute stenting in the first 3 days or 5 days. So the thing here was the hemorrhagic transformation, and there was no flow limiting stenosis.
Great, thanks Dr. Ali. We have Dr. Thamer Nuh. حياك الله Thamer.
الله يحييك أحمد. I'd like to also thank the team for presenting a very what looks like a very challenging case. What I had a question. My understanding from the presentation is that the injury or the pseudoaneurysm was at the level of the bifurcation. Is that correct?
No, it was just distal to the bifurcation.
Yeah, and just distal to the bifurcation. So this is in zone 2 in the neck, which is surgically accessible. I'm just going to play devil's advocate here. I'm sure this is a difficult case, and in retrospect, everything seems to be clear. But the whole idea in our approach to to blunt cerebrovascular injury is to try to attempt to prevent a stroke or a neurological incident from happening. It's not to treat it or revascularize it after it happens. And so if the patient arrives, we have to, normally I would argue that we assume, or we would give him the benefit of the doubt that he's not stroked already at day 1 at presentation. And if he's not a candidate for endovascular therapy by stenting at the initial time because of the dual antiplatelet drugs and the need for surgery, I would have argued that surgical exploration of the neck by a vascular surgeon, identifying exposing the bifurcation, repairing the actual artery, and maybe at the time they can also look at the intima and tack it if there's a dissection. So my argument is, why wouldn't you consider taking him emergently to the OR and give him the benefit of the doubt that probably he did not stroke yet? Thank you very much.
Dr. Tariq. Dr. Tariq, can you hear us?
Yeah. معلش كان unmute problem.
Hello?
Yes. Can you hear me?
تفضل Dr. Tariq, تفضل.
Actually, we were thinking of what Dr. Thamer saying. The problem that what we held us from the OR is the higher injuries in the internal carotid, and the type of injury. If we have like a transection or something, then we'll maybe take him to surgery. We were thinking that stenting is more, as you know, that the study is proving that the comparison between the stenting and surgery, there is no functional or survival difference. I don't know if he might benefit from surgery, yes, as Dr. Thamer mentioned, but that time after the injury, we were considering the stenting more than a surgical intervention. It's a valid point. Yes, it might change anything, but again, the risk of stroke is higher as initial presentations. That's what we were thinking that time.
يعني هو طارق الله يعافيك يعني I agree with you, absolutely agree with you that a less invasive approach by stenting is probably the way, would be my probably the first choice, but the way where I might have treated him differently is the minute I would try to get stenting acutely at presentation, and if this proves to be not doable either because of lack of access or risk of complications, I would have pushed him to the more conventional, maybe more risky surgical approach by actually exploring, especially that it's in a surgically accessible area. Again, retrospectively, it's very easy for me to say that today because I know what happened, but I'm just putting it as a alternative way of managing. Thank you.
I think that was maybe a valid point, but I thought from the imaging that it was actually more behind the mandible, more zone 3 than zone 2. Isn't it right, guys? Or
may I comment here? Excuse me.
تفضل دكتور علي.
If you don't mind, I saw the image in the CT, and you might correct me if I'm wrong. It is away from the bifurcation. Yes, it is below the base of skull, but it's away from the bifurcation. In the image, I question accessibility.
Yes.
Okay, bifurcation is at thyroid level, between maybe it's a vertebra, it's between C3 and C4. It's accessible bifurcation, level of thyroid. But above that, the more you go up, the more it becomes more difficult. The more we go up, even tying is difficult. Hemorrhage control is difficult. What about repair? So it is not just after bifurcation. It's a little bit away if you review the image again. And to tell me if you think otherwise.
دكتور علي had a point to say. Please, تفضل دكتور علي.
Yes.
تفضل دكتور علي تفضل.
Hello.
تفضل.
Yes, I agree with Dr. Abdullah. I think it is distal to the bifurcation. It's in the beginning of the skull base, and it's not only it's a surgical repair, so you need to have enough exposure. Personally, I do cases of carotid endarterectomy. I do open and stenting, and it's not at the bifurcation. Like if it is in the bifurcation, I agree with Dr. Nuh. We can take him in the OR. Although there is one important point here that we have to do an MRI, because the stroke that he had, probably he had it early at the dissection. So if we do an MRI was not done at that time, but I mean, if we will go ahead, even if I'm considering stenting, I will not put a stent unless I do an MRI and rule out stroke. So if I did an MRI at the time of the CAST diagnostic study, and I found that he had a stroke already, definitely I will not stent him because there is a risk of hemorrhagic transformation. So that was the key. And possibly due to the MRI that we did and the CT that we did with the hypodensity that we saw, I believe that he had the stroke initially when he had the dissection immediately.
Great. يعطيكم العافية دكتور علي, دكتور طارق, everyone who commented. I think for the sake of time, Dr. Abdullah is going to present to us about the guidelines for 5 minutes, and then we can move on to the second case, which is also promises to be as interesting as this case, inshallah. تفضل دكتور Abdullah.
Okay, sure, Dr. Ahmed. So about the guidelines, I will try to be quick, inshallah. This is the evaluation and management of blunt cerebrovascular injury practice management guidelines from the Eastern Association for the Surgery of Trauma. At the beginning, it's mainly retrospective systematic review with meta-analysis, and they are using grading of recommendation assessment, development and evaluation grade methodology. a task force of a practice management guidelines committee of Eastern Association for Surgery of Trauma perform a systematic review and meta-analysis of currently available evidence for population intervention, comparison, and outcome question were developed to address diagnostic and therapeutic issue relevant to blunt cerebral vascular injury. So starting with the screening criteria for blunt cerebral vascular injury, we have Denver criteria and Memphis criteria, which I'm sure everyone is familiar with. I have to speed up a little bit. The Denver grading scale for the blunt cerebral vascular injury, grade 1, luminal irregularity or dissection with less than 25% luminal narrowing, 2, more than 25% luminal narrowing, intraluminal thrombus or raised intimal flap, 3, pseudoaneurysm, 4, occlusion, 5, transection with a free extravasation. And if we want to apply our case here, it's going to be like 2/3. So the question that came up with, it's 4 PICO question. The first one, it's talking about should in adult patient with blunt polytrauma, should a screen protocol versus no screen protocol be used to detect BCVI? Question number 2, in adult patient with high risk cervical spine injury, should a screening CTA versus no screening CTA be performed to detect BCVI? This is for A. For B, in adult patient with low risk cervical spine injury, should a screening CTA versus no screening CTA to be performed to detect BCVI? Question number 3, in adult patient diagnosis with BCVI, should antithrombotic treatment versus no antithrombotic treatment be administered to decrease the incidence of stroke or mortality? Question number 4, in adult patient with grade 2 or 3 BCVIs, should routine endovascular stenting as an adjunct to a antithrombin treatment versus antithrombin treatment alone be performed to reduce the risk of stroke or mortality? The total of the study involved, it was a 343 study. At the end, it was around 33 that included in the answering the questions. Starting with the first question, either to screening protocol versus no screening protocol to detect BCVI injuries. The recommendation came in formulating a recommendation for BQ1. We considered the most polytrauma patient would benefit from and place a high value on standardizing approach to detection of BCVI. So based on this evidence, 15 author, 88% voted for string recommendation, while 2 they are voted for conditional recommendation. So they are recommending for using screening protocol for detecting of BCVI in adult patient with blunt polytrauma. For BQ2, which is considered A and B for the high risk and low risk cervical spine injury, it came as they are recommending screen CTA in the patient with a high risk cervical spine injury to detect any type of BCVI, while in the low risk cervical spine injury, they are conditionally recommending the screening patient with a low risk and depend from case to case. For BQ3, the question was in adult patient diagnosed with BCVI, should antithrombin treatment versus no antithrombin treatment be administered to prevent stroke or mortality? The recommendation came as they are recommending to start the patient on antithrombin to decrease the incidence of both stroke and mortality. In BQ4, in adult patient with a grade 2 or 3 blunt cervical vascular injury, Should routine endovascular stenting as adjunct to the antithrombin treatment versus antithrombin treatment alone be performed to reduce the risk of stroke or mortality? The recommendation came as they are recommending, strongly recommending against placing a stent for every patient with grade 2 and 3. So this is the summary of recommendation. Just to summarize them, they are recommending for screening protocol to detect BCVI, and they are recommending as well CTA for those with high risk cervical spine injury. And there is conditional recommendation to perform a screening CTA to detect blunt cerebrovascular injury. And they are recommending as well using of antithrombin treatment to prevent both stroke and mortality. And the last one, an adult patient with grade 2 or 3 blunt cerebral vascular injury, we recommend against the use of routine endovascular stenting as an adjunct to antithrombin treatment to decrease the risk of stroke.
Okay.
In conclusion, the recommendation, as we just mentioned it in the previous slide. And thank you so much to having us today and to allowing us to present our case. Thank you so much, Dr. Ahmed.
Thank you very much, Dr. Abdullah, Dr. Tariq, Dr. Ali. يعطيكم العافية جميعا. I'll conclude this case with a comment from Dr. Mohammed Bawazir, our previous boss, and his and our close friend. Please, Dr. Bawazir, please. I will unmute you now. تفضل.
السلام عليكم ورحمة الله وبركاته.
وعليكم
ترى
السلام.
ماني بس حبيبي الشابتر is our chapter. It's for everyone. Started together. Thanks Abdullah, thanks Tariq, thanks Dr. Ali for this excellent case. I really enjoyed the presentation. I just want to ask Abdullah, since you were managing this case, what did you learn from it, and would you do anything differently after reviewing the evidence? Shukran.
Well, I learned from this case, not every neck trauma going to OR. Actually, I was asking Dr. Tariq, we had a great discussion in the CT scan room, either to take the patient or not to take the patient to the OR, considering that the appearance of the trauma or the sudden appearance of the hematoma, can we consider it as an expanding hematoma or it's not expanding hematoma? He was convincing me that since we are discovering the hematoma, it's the same hematoma, it's not getting increase in size. According to the CT scan image, according to the location of the hematoma, the best outcome to go for angio immediately instead of going to the OR immediately. I learned that discussing the option with all of the teams, as what happened with this case, Dr. Ali was presenting immediately once we communicate with him. Dr. Ziad al-Rajhi, the maxillofacial consultant, he presents immediately, and all of the consultants involved in managing this case, I believe it will give the patient the best outcome. Is there anything I will do it another way? I think no, and I'm learning a lot from this case actually.
يعطيك العافية. Thank you very much, Dr. Abdullah. I think what you said is key about trauma is multi-system and it's multidisciplinary, and it's very nice to see a multidisciplinary approach to such big dilemmas. It will be exciting to hear an update about your patient, inshallah, once he extubated and he's doing better, bi'idhnillah. Thank you very much. We will move to our second case, which is also a neck case, a dilemma, but this time it's a penetrating injury. and it's going to be presented coming from King Saud University Medical City, presented by our also senior fellow, Dr. Mshari Shalhoub, who is also an assistant consultant from Princess Noura University Hospital, and supervised by Dr. Thamer Nouh, who's our associate professor and consultant in trauma and acute care surgery from King Saud University Medical City. Also promises to be an interesting case. They actually had some questions to be asked for the audience, so we're going to have some polls at intermittent times during the case. Most of the polls have actually two choices, and if you feel that you are not sure about any of the choices, then you can just leave it blank when we ask the polls. Without further ado, I'll ask Dr. Mshari to present his case. يعطيك العافية دكتور مشاري.
Assalamu alaikum. Good evening, everyone. Thank you, Dr. Ahmed, for the amazing intro, and thank you, Dr. Abdullah and Dr. Tariq, for the case and your amazing work and efforts on the previous aforementioned case. This will be a very tough act to follow, and I'd like to thank also Dr. Thamer Nouh for his continued supervision and his mentorship through this case specifically, and the fellowship in general. I'll just start by introducing myself. I'm Dr. Mshari Shalhoub. I'm a trauma ACS fellow and assistant consultant at King Abdullah University Hospital, Princess Noura University. So I'll start to begin with this case presentation. We had a 29-year-old gentleman who had a history of depression on fluoxetine and venlafaxine. He was brought to the emergency department by the Red Crescent after a suicidal attempt that occurred at 6 a.m. From the same day of the presentation. According to his family and brothers, that they were involved in a quarrel and heavily disputed discussion. And after that, they said that the patient stabbed himself in the right lateral side of his neck with the knife twice, which were witnessed by his brothers, who called the ambulance and accompanied him. Upon arrival, he was alert, conscious, initially hypotensive with a blood pressure of 90/72, heart rate of 98 beats per minute. And as per the emergency physician, that there was some amount of bleeding or oozing coming out, so they applied pressure dressing and they activated the trauma code. So the activation was somewhere around 7 a.m. So upon our assessment, patient was conscious, protecting his airway, saturating 100% on non-breather face mask. Breathing-wise, he had equal bilateral entry with no added sounds and equal chest rise. Upon our assessment, he had a blood pressure of 100/75, heart rate of 106. He received total resuscitation of 1 liter of normal saline and 1 unit of uncrossed blood. And there was minimal amount of oozing, but no active bleeding or visualized hematomas. Disability-wise, he had the pupil that was reactive to light, GCS 15/15. Exposure-wise, he had 2 isolated stab wounds, one 6 centimeter long horizontal wound at zone 1, around 3 centimeters above the right clavicle, and another smaller wound, 2 centimeter in size, longitudinal, in the zone 2 laceration, 7 centimeter below the angle of the mandible. And I apologize for not having any pictures to depict these findings, since we were pulling all-nighters and we weren't able to take the photos that we needed. And upon secondary survey, patient didn't have any other visual noted injuries. Patient was fully conscious, but due to his depressive episode, he was not communicating with us. He was on talking very low voice. He was refusing to let us hear his voice. So it was difficult to assess his findings, but there was no signs of any expanding hematomas. And by examination, we were palpating some crepitations around the neck extending to the suprasternal notch. So we did the chest X-ray, had a centralized trach, no pneumothorax, no costophrenic angle. The costophrenic angle was intact, no signs of pneumothorax. So this is going to be our first poll question. So in this case now, would we take the patient to the CT scan or we proceed to OR? So the given information, just to remind you all, patient was maintaining a blood pressure of 100/75, heart rate of 106, protecting his airway, no clear signs of active or significant active bleeding. Patient was not in shock, only received 1 unit of blood, and he responded well to that. Okay, so we can see the poll, the majority are going with the CT scan now. So approximately 79% for CT and 21% went with operative exploration. Okay, so 81% went for CT and 90% went for operative exploration. Right, so we will continue with our case now, and we'll so we went for a CT scan, and this is our initial image. So as you can see in this image here, you can appreciate that there is a subcutaneous emphysema, and here where the arrow is pointing, this is our area of entry. This is our wound site, and you can see that the subcutaneous emphysema is extending all the way to the other side. Here's another view. As you can see, the emphysema is extending all the way down to the substernal notch, and going all the way to the lateral side. And here we can appreciate that there is a right laryngeal displaced fracture here, and the thyroid cartilage right here. And here's just another image to depict the subcutaneous emphysema. More images as well, just to depict that. No other injuries were noted in these photos as well. And this one here is an image showing that there's no evident picture of vascular injury. And after we discussed it with the senior radiologist, they concluded the same findings we mentioned. Only a picture of significant subcutaneous emphysema, as well as a right laryngeal fracture, and no visualized vascular injury. So in this case now, what is the option? Would you want to take the patient to OR or admit for observation, since he is stable, doesn't have any significant heart signs or any signs to worry about airway or vascular compromise?
Do we have the option to say what we're going to do in the OR, or just operative exploration?
For now, it's exploration for what exactly, Mr. Mohammed? Here it's just a general rule. Would we explore this patient, or we'll just observe him? We can close the wound and observe.
طيب خلينا نحط operative exploration ونشوف ايش تورينا.
This is a very close one, Dr. Mshari. You have to.
واضح من البول انه we have a split audience here.
So we're almost at 50-50. So half the people say we'll observe and the other half will explore.
You guys see the results. So 45% want to explore and 55% want to do close observation.
لأنه السيرجيكال exploration هذه كلمة عامة. It can mean anything.
You look way too much into MCQs, Dr. Bawazir.
طيب.
I guess what we mean, Dr. Bawazir, is formal neck exploration.
Yes.
Oh, okay.
Formal neck exploration. That would be what we mean by operative exploration is formal neck exploration. طيب, so we'll continue.
انت ممكن تاخذ المريض, you can take the patient to the OR and not necessarily surgically explore him, do other things in the OR.
Yeah, I will come to that.
طيب عشان ما بدي احرق القصه عشان حسكت.
Right. So we'll continue with our case. So we took the patient to OR for emergency neck exploration for zone 1 and 2 stab wounds. Patient was following induction intubation in the operative room under controlled environment with our trach set on standby. We began our procedure by doing an EGD, which we did, and it showed no obvious injuries to the esophagus at all. Unfortunately, I wasn't able to take any pictures of the EGD itself. We also performed a bronchoscopy, and generally it was equivocal since we didn't see any frank areas of injury or clear area of injury. There was a questionable area in the posterior right side of the trachea, which was worrisome for us that it could be a sign of an injury. There was a minimal amount of oozing and a questionable hematoma that we noted. So what we did, we started by extending on the first wound, the lower one in zone 1, by extending it into a supraclavicular incision, where we firstly encountered some small oozing vessels, which we controlled by the ties and clippings. And we noted inferior to the right subclavian artery, there was a deep cavity where we elected to explore it and to see. And just to inform you, there was no significant bleeding at that time, any worrisome bleed. So after we explored this cavity, we started to have a significant large amount of venous bleeding, which seemed to be a major vascular bleed. So what we did, we extended our zone 2 incision where we did a formal neck exploration. Our main concern at that time was, could it be from the right internal jugular vein or not? So we went to try to gain proximal distal control of the IJ, but by doing so, we found the IJ was intact. So during that, we just applied pressure over the cavity itself, where we controlled the bleeding, and then we contacted vascular surgery, which they came intraoperatively. So we started by isolating the major vasculature, including the right subclavian artery, right vertebral artery, and the thyrocervical trunk, and we achieved good proximal and distal control of it. We noticed a small branch of the vertebral artery was bleeding. It was questionable. It could be the transverse cervical artery, which was controlled by clipping. And during our exploration, we realized that the brachial plexus was transected, and we also noted a right laryngeal laceration. As you can see here, this is our control of the right subclavian artery, and you can see here, this is our vertebral artery right here. And this is the pack where we used to control the bleeding itself. So this was inside the cavity, and this is the cavity that I mentioned. So as you can see, this is our initial photo of the case. The field was extremely dry. There was no significant bleeding or anything, but when we explored this cavity here, that's where we noted our presumed injury. So what we did, we assumed that this was a bleeding coming from the most likely from the venous vertebral plexus, since we noted that the point where the blood was coming was from between the vertebral bodies. So what we did, we controlled it, we could not control it with ties or clipping, since we could not access it. We can barely just apply pressure to it. So what we did, we applied a bone wax plug and tacosir. So, and now for our next poll question. In this case, would we conclude our repair and finish the rest of the injuries he had, such as the brachial plexus injury and the vascular and the laryngeal injury? Then we close and observe, or we proceed for a radiography. Okay, so we can see the majority, around 85% or 82%, are leaning towards angio, and 18% are more towards to observe the patient. When we say observe the patient, we can even do a CTA afterwards to see. Or we can also do an angio if we close. So would you close or from OR to angio?
It looks like the majority wants to proceed for angio. So what did you guys do?
Okay. So we proceeded to take the patient to a neurointerventionist, where we shifted the patient directly from OR to the angio suite. We started by, now as you can see here, this is our common carotid artery up, and this one here is the right subclavian artery. As you can see, there's, excuse me, so as you can see, there's no clear signs of injury or any extravasation from either. And you can see here, this is our clips that we use to control the branch from the vertebral artery. Here we can appreciate this is our, this is the right vertebral artery. And the only finding here that was of concern was this irregularity right here. But the most likely cause of it was from our vessel loops and our control of the vertebral artery itself, since it did not seem to be injured or anything during our exploration. And here we can see the upper anatomy of it. So here, this is the right inferior thyroid artery. As you can see, this is the thyroid gland itself. And here, this is a ligated suprascapular artery. And here, this is the transverse cervical branch. And then you can see there's still no active extravasation or any active injuries noted. And in this image here, we can appreciate the upper branch is the deep cervical artery here, and right down here, this is the highest intercostal vessels, and they appear to be also intact with no signs of visible injuries. As you can see here, this is the common carotid artery. It's filling nicely with no sign of injuries or any attenuation. Here we can see this is the right IJ, the right jugular vein. It's slightly dilated because of the pressure we applied before, so it's got slightly distended, but otherwise there was no sign of any significant injuries. And during our angiography, we decided to go for also a left vertebral artery assessment, just to make sure if we needed to ligate the right side, we'll know that this will be patent and it will be a dominant left vertebral artery. So as you can see here, this is from the left vertebral artery, and we can see that both hemispheres of the brain were fully perfused. So in the case that we need to sacrifice the right vertebral artery, we will still have good perfusion for the brain. And just for our own knowledge and teaching purposes, from a CT scan point, in our CT, we could not appreciate the venous plexus bleeding, but this is how it should look like. This was not present in our patients. So this is the normal side, because you can see it's straight, like there's no extravasation or anything. And on the other side, you can appreciate that there is some form of extravasation coming from the venous vertebral plexus. So then after that, we concluded our angiography that there was the bleeding was controlled with our bone wax. So we went back to OR to complete the findings we had. So we also contacted the plastic surgeons. They came in, they joined us intraoperatively, and the finding was there was a full tear at the level of C5, partial tear at level of C6, 80% tear, and they could not appreciate C7, so it was repaired by proline sutures and applied glue. And we also called the ENT team, regarding to assess for the laryngeal fracture, the one we had. So the finding was a displaced fracture of the right thyroid alar cartilage and the lower border. They repaired it with proline 2O. They did the direct laryngoscopy, showed only severe supraglottic stenosis and posterior glottis edema, and distal airway appeared clear. So the final question for the poll is, would you do a tracheostomy for this patient or not?
Okay, again, people are kind of split on that one, Dr. Mshari. We have 55% advocating for tracheostomy and 45% saying no need for tracheostomy. It's very close.
Yeah, it's getting even closer. So in these cases, like the trauma teachings in general, that any laryngeal trauma, it's better if you have any concern about any injuries in the tracheal or the laryngeotracheal separation. It's better to have a tracheostomy just to secure the airway. So in our case, we did place a tracheostomy by the NT team, and then we placed 2 drains, and the patient was shifted to the ICU under mechanical ventilation, and he was sedated for a couple of days. So post-operative course, I summarized it all on one slide. So patient had a very good recovery post-operatively. His hemoglobin was stable at like ranging from 11.5 to 12.6, so no significant drop there. Never required transfusion in the ICU. On his second day post-operatively, patient was off sedation. He was awake. He was tolerating pressure support ventilation. Never required inotropes. And one of the main reasons why he was in ICU as well was just to have close one-to-one nursing because of suicide watch. On the 4th post-operative day, he was weaned off the ventilator completely, and he was put on the ATC mask. And on the 7th post-operative day, which was yesterday, tracheostomy was downgraded to a fenestrated tube and corking, and the plan was to start corking by today. And as with regards to his brachial plexus injury, his motor and sensory deficits were involving mainly C5, C6, and C7. So he had sensory loss mainly over the lateral aspect of the right arm, forearm, and mainly his middle finger. So this goes more with the C5 and C6 sensory pattern. And with regards to his motor loss, it's mainly in his elbow flexion, wrist extension, and flexor carpi ulnaris functionality, which goes more with C6 and C5 and C7 injuries from a motor point of view, from his myotomes. So the plan now for him, just hopefully if he's tolerating the corking, maybe within the next couple of days, he will be decannulated. He'll have a full psychiatric evaluation. And then we will see if he will be either fit for discharge or he will need to be admitted into a psychiatric ward for further evaluation and readjustment of his medication. Right, so with this, I conclude the case itself. I just have this quick paper I want to review in relation to our case. Should we take any questions now, Dr. Ahmed, or should I proceed?
يعطيك العافية, Dr. Mshari. This was a very interesting case. As usual, it'd be nice to hear the input of the trauma consultant, Dr. Thamer, overseeing the case. This was a very interesting case. Again, we will use the raise hand functionality for any comments or any questions. And I'll give the floor to Dr. Thamer to give any comments before we can hear about your paper.
Thank you, Dr. Mshari, and thank you, Dr. Ahmed. I mean, this was the last case of a very interesting week for me covering trauma. But again, when what was special is that when I arrived after the trauma activation, the patient was completely hemodynamically stable, lying in bed. His family was there. I mean, a lot of the decision to go to the OR was, I guess, questioned by many in the trauma bay. Given the CT scan did not show any major vascular injury. To be honest, in the operating room, once we started the exploration, we had a real gush of blood to the point where I was very worried. I was very afraid, to be honest, because it was very deep in the neck. Just at the thoracic inlet. And so my initial approach was that I needed to try to get some sort of, to position myself in a way where I can get proximal control, and we were ready to even to do a sternotomy just to try to get control within the chest if need be. Eventually, I elected to get help from Vascular. And with Vascular there, we proceeded, we were ready to open the chest, but we proceeded just to try to see if we can control this from the neck. Ultimately, it was a very weird bleeding. It was coming from deeper than even the vertebral artery and the subclavian vessels. And then when you put your finger, you can feel the bone, and the blood is coming from a hole between the vertebral column. And so again, we continued our exploration. Ultimately, the only way we could control it is by getting the bone wax just to plug the hole. In retrospect, it's probably a big vein attached to the bones that was opened up. It's weird that he got all the way that deep without cutting either the carotid or the subclavian or the vertebral vessels. The other point that I want to point out is really, we did not have any inclination that he cut his lateral cord of the brachial plexus. The patient was, although he was alert and trying to respond to us, but because of his psychiatric issue, he was not following any of the commands very well. So we could not pick up that the fact that he had neurological deficit in his right arm preoperatively. It was only during the exploration that we found that the brachial plexus was injured. And I think what was good to explore is that giving early repair of a clear transection of the lateral cord of the brachial plexus will probably give him the best chance at recovery. There wasn't enough time for inflammation or fibrosis to happen, and it was very clear. Plastic surgery was able to put it to approximate it and put it back together. I think it was a very interesting case, and I would like to hear what the other leaders would think about it. Thank you.
Yes, we have Dr. Mohammed. تفضل محمد.
شكرا جزيلا. Excellent case and excellent outcome and very safe approach. Thank you so much for the team for caring for this patient and for sharing this case. I'll be honest with you. In this case, if I have this clinical data and the radiology findings where we don't have evidence of vascular injury and clinically we don't have a heart sign, and even in the airway injury, he is asymptomatic, probably I would observe this patient. But like they say, if there is any doubt, go for exploration. And looks like that the trauma surgeon has doubt, and he went in, and it was good for the patient. This neck trauma, unfortunately, is a black box for general surgeon, and we can see that in the periphery frequently. And usually we try our best to encourage surgeons to explore and don't be afraid of negative exploration. It is part of our job, especially if there is any doubt. So maybe here in this case, I would like to, there are many points. This, if we talk about neck trauma discussion this night, we can keep it on until 2-3 hours. But I would challenge the decision of the tracheostomy. The larynx healing is, we don't have a separation, we don't have high grade, and the healing process is amazing in the larynx. Probably if we keep the ETT for a few days, then we do just formal extubation, probably is also a good option. Tracheostomy probably is reserved for complex injury in the airway, and even prior exploration. If the patient has a laryngeal injury or tracheal injury, and it is less third of circumference or less than 2/3 of circumference of trachea, and patient is asymptomatic, there is no compromised airway, no threatened airway, and he is comfortably breathing room air. Those usually are successfully observed, and they succeed with the conservative management. And we can see the split. I think the split in the tracheostomy decision does not make sense to me, but maybe I can share there is a split, but I think my opinion, maybe we don't need to go to tracheostomy. Thank you so much. Thank you for the case. Amazing.
Thank you, Dr. Muhammad. To be honest, I asked to add the question or the poll about the tracheostomy because I had the same feelings as you at the end of the case, that maybe the patient did not need a tracheostomy to be inserted. Again, going through the thought process of the ENT surgeon that was with us, I think I had the benefit of the doubt of doing the bronchoscopy, the flexible bronchoscopy ahead of time at the beginning of the case. So I was very happy, and maybe I disagree a little bit with Mshari. There was an area at the posterior, just below the vocal cords, posteriorly, where there was an area of blood that I suctioned. So the only reason there's blood in the airway is because there is an injury, but we couldn't see any significant injury to the from the inside. From the larynx, it was a comminuted fracture. So there's multiple pieces, and the ENT surgeon basically she stitched it together, tried to reduce every piece in place. And I think the reason she elected to do the tracheostomy is that she wanted to examine the larynx from the inside to make sure that there is no major disruption of the mucosa. And she wanted to extubate the patient to do a rigid bronch under safe circumstances, and this would only come with the tracheostomy there. So basically what she did is she did the tracheostomy, repaired the larynx, did the tracheostomy, extubated the patient, and then closed the wound, and then did the rigid bronch to look at the airway from the inside. It's classical teaching. I think she was safe, but I agree with you. Maybe this patient did not need a trachea.
دكتور باوزير تفضل.
We can't hear you, Dr. Muhammad.
He's still muted somehow. I guess we can move on with your paper presentation, Dr. Mshari, and then we can have some closing remarks and comments.
Okay. Right. So this is this study I found. I can relate it to our case. It's a penetrating neck trauma, radiological predictors of vascular injury. It was done in 2019, and from the European Archives of Otorhinolaryngology. Okay, so so in this paper, they stated that the penetrating neck trauma predicts a poor outcome and requires usually surgical intervention exploration. So a multi-detector CT, which will be abbreviated MD-CT angiography, is available, a non-invasive diagnostic tool for vascular injury. So in this study, they investigate the diagnostic accuracy of radiological signs and their implication on the patient management in the setting of penetrating trauma in conjunction with the clinical findings. So this is a retrospective cohort study involving all patients who sustained a penetrating neck injury between 2012 and 2018 in UK. All patients were included. The only exclusion criteria was if the platysma was not penetrated, and if the patient was too unstable for pre-op imaging and was taken to the OR directly, and patients who underwent the scan but did not have formal exploration afterwards, or did not have adequate imaging of the questioned area, for example, incomplete neck imaging or chest imaging. So clinical data and findings are compared to radiological findings on the time of admission, and along with clinical data and operative findings collected from medical records. So, and all cases that were seen by two head and neck radiologists, they were blinded to the operative findings and the outcomes. And they reported on what is direct and indirect signs of vascular injury. And then the findings were compared to the operative findings. And just here is just a quick zonal the separation of the zones from zone 1, 2, and 3. So in these cases, and usually, so several authors shown that site of entry does not accurately predict the internal injury itself, and that sometimes from zone, for example, 2 can lead to zone 1 or vice versa. So all the structures are at risk. That's why they advocated the no-zone approach for penetrating neck injuries. That's why they usually should focus more on the clinical assessment for hard and soft signs. So here, this is just what they defined as their definition of what the hard signs and soft signs are. And here is the for the radiological findings of what they labeled as direct and indirect signs of vascular injury. So any prevascular hematomas or fast stranding considered indirect, but any pseudoaneurysm or dissection or fistula formation is considered as a direct sign. And mainly the most significant hard signs they found was either expanding of hostile hematomas, shock, or active bleeding. So, in the results, so they had a total of 157 patients with penetrating neck injury. 67 of them met the inclusion criteria. There were 56 excluded patients. Sorry, the excluded patients, 56 of them did not go for the CT scan because they were too unstable. Or in 31 patients, they underwent the imaging, but they did not have any surgical exploration afterwards, so they were excluded. And 3 patients because the CT images were not available or incomplete imaging of the neck. So all patients attended via the emergency departments, and they were assessed by the by otolaryngology registrar and consultant following initial assessment by the trauma team. So the most common symptoms of the initial assessment was bleeding in 52% of them. Hard signs were present in 22% of the patients. 100% of them were presenting with active bleeding, 20% with expanding hematomas, and 13% with shock. And soft signs were present in 46% of these patients. 42% of them showed only a non-expanding hematoma, and 33% showed venous oozing. Here, just the main patient characteristics. But so for, I'm going to focus mainly on the signs. So 22% had hard signs and 49% had soft signs. And 39 patients, or 58% of them, had the CT only, and 40% had CT angio, and only one had a CT and an ultrasound. And as you can see, the most common zone of injury was zone 2, with 52% of the injuries were mainly in zone 2, and we have 11 in zone 1 and 2, 8 in zone 2 and 3, and 3 in zone in all 3 zones. So for the radiological investigations, in all of the CT scans, they revealed subcutaneous air, but they did not specify the extent of the subcutaneous air. Since I know in some references, they labeled subcutaneous air as only a soft sign, but in some cases it is considered as a hard sign, especially if it's extensive or reaching the, for example, the mediastinum or the contralateral side, which was similar to what we had in our case. So in 39 patients, there were direct signs of vascular injuries, and in 19, there were both direct and indirect signs of vascular injury. And only one patient had only indirect injury, so indirect evidence of vascular injury. So in 8 of these patients as well, they had no signs of any injuries on CT scan. So here they just they showed us the statistics in the test itself and its sensitivity and specificity. So it just showed that in the presence of the direct or indirect signs on CT scan, it shows an 82% sensitivity and 9% specificity. And the direct sign showed only 52 sensitivity with 81% specificity. As for the hard signs, showed a sensitivity of 43% and 86% specific. And for the combined hard clinical signs with the direct signs on CT, it was 97% specific and 26% sensitive. So for them, the intraoperative findings, major vessel involvement, mainly the named vessels were seen in 7 patients, and 13 patients suffered an arterial injury, and the overall rate of direct vessel ligation was or repair was 36%. They did not elaborate exactly on who went with ligation or repair or what type of repair that happened. As for the neck restoration, they revealed no named vessel injury in 64% of them. And this subgroup, there was mainly diffuse oozing, which was managed by either bipolar diathermy or clipping. So in the results, so the rate of negative neck exploration in patients presenting with hard signs in the study was 23%, which is comparable to negative exploration rates reported elsewhere from 10 to 28%. So they had an average acceptable rate of negative neck exploration. So the use of the CT angiography in select patients presenting with hard signs reduced the number of these negative exploration to 15% from their numbers. These figures are for finding vascular injury only, and therefore they do not represent the true overall negative exploration. So they did not include the aerodigestive injury tracts. So the predictive value of the indirect radiological signs of vascular injury alone was low, with only 12.1% of them having significant vascular injury, and which is found at neck exploration. However, the combined use of direct signs with clinical signs resulted in specificity of 97% of vascular injury, or almost 98%. Also, 23 patients who in the OR were found to have vascular injury requiring intervention. The 19 had either direct or indirect evidence of vascular injury on blinded review and giving a sensitivity of 82%. And of the 33 patients with indirect radiological signs, only 4 of them were found to have clinically significant vessel injury. So when only direct radiological evidence of vessel injury was considered, 9 of the 19 patients had clinically significant vascular injury. So the accuracy of the direct signs on the CT scan predicts vessel injury was 71%, with a negative predictive value of 76%, with a p-value of 0.006. This was slightly superior to using hard signs and clinical assessment alone, which the accuracy was 73% and gave a negative predictive value of 75% and the p-value of 0.005. And I don't think that these numbers, just correct me if I'm wrong, Dr. Thamer, But for me, they don't seem to be really that significant either statistically or clinically with these numbers, especially with the small sample size. In addition, the hard clinical findings and direct evidence of vascular injury, it was 97% specific and 26.1% sensitive that required intervention, with a negative predictive value of 71 and positive predictive value of 85, an overall accuracy of 73%, with a p-value of 0.005. Excuse me. And the negative predictive value of clinical assessment for vascular injury alone was 72.5% and the 84% specific, which is lower than the combined clinical and radiological assessment, which was approximately 99%, suggesting the reduced false positive rate with the utilization of direct science on CT scan. So when utilizing direct radiological evidence alone in the 19 patients, they had clinically significant vessel injury. And the accuracy of direct science showed vessel injury was 71.6%, next predictive value of 76.6%. I think this slide is also repeated, so I apologize for that. So here, yeah. The rate of negative neck expiration in patients with soft clinical signs, they only fell from 85% in patients without direct radiological signs of vascular injury to 44% with direct signs of vascular injury. 4 of 5 patients confirmed internal jugular vein injury were identified by direct signs radiologically, and all 3 patients with carotid injuries were correctly identified as such radiologically. Of the 32 named vessels identified as being injured in the operative records, 15 were identified at the site of direct or indirect signs of injury radiologically. So to conclude, it showed that they concluded that the specificity of the combined clinical and radiological assessment was up to 97.7% opposed to the 86% for clinical assessment alone. So in an unstable patient with hard clinical signs of injury, radiological imaging is not indicated and immediate exploration is mandatory. In stable patients with clinical signs of vascular injury, this study suggests that CT is a valuable tool in predicting the site of injury. So in patients with hard signs and direct radiological evidence of vascular injury are unlikely to have negative neck explorations. However, patients with no hard signs or vascular injury and only indirect radiological signs could be observed rather than undergo immediate neck exploration. So they demonstrate the value of the CT and assessments in using indirect and direct radiological signs in penetrating neck injury. So it is evident that imaging is not a replacement for clinical assessment, but rather they complement each other as part of the no-zone approach to reduce the rate of unnecessary surgical neck exploration. The findings suggest that the CT is useful in stable patients with hard or soft signs of vascular injury. And while a positive scan alone does not guarantee the presence of a clinically significant injury, but signs are more accurate as a predictor than indirect signs. The direct signs are more accurate than indirect signs. And in addition to hard clinical signs, they can accurately predict a significant injury. So CT is therefore recommended in stable patients with clinical signs of vascular injury to localize the site of injury and reduce the rate of negative neck exploration. So the usefulness of CT is less clear in patients without clinical evidence of vascular injury, and the circumstances, a period of observation is more appropriate. And just for me to add my own thoughts on this, especially with the case that we just had, like in our patient, he had only subcutaneous air, no vascular evidence or no evidence of vascular injury by CT scan. He was vitally stable. He only had questionable aerodigestive tract injuries only. That was what we visualized. So the option was to either go to observe or to operate. So in such case, I was glad that we went to explore the patient, and there was a missed injury, or not, I would say missed, but an injury that was not visualized by CT scan, but we were able to visualize, to find it by exploring the area. So that's why I think it's better for especially penetrating injuries in zone 1 and 2, especially in zone 2, we need to be more vigilant with them, and we need to explore them, to be more liberal with our exploration rather than observing them. I'll take the questions now. Thank you so much. And any comments, Dr. Tamer?
Thank you, Mshari. And no comments. I think these papers, the pendulum is swinging to the extreme other side, where everybody's trying to avoid the negative neck exploration and trying to accept any non-management of potential injuries, just to avoid the risk of, just avoid going to the operating room. I think personally, one number that stuck with me, you said 9 of 19 patients that had injuries and that were dealt with in the operating room in this set of patients did not have any radiological evidence of injury. So I think for me, and I quote this from my fellowship director, we're in the business of finding injuries. And for me, one patient that has an injury that is missed is one patient too much. And if that means that I have to accept some risk of negative explorations, in my practice, I accept that. And I would call our patients that he had missed injuries. He had a brachial plexus injury that was not picked up on the CT scan that needed repair acutely. And he had a major venous injury that could have killed him. I mean, remember at the end of the case, we were worried that we don't want to extubate him because we thought if he coughs, if he increases intrathoracic pressure, that he will start bleeding again from his neck. And to me, these types of patients, I want to go home and be able to sleep at night without thinking, if the patient coughs, he's going to bleed to death in the hospital. Thank you.
Thank you very much. We have Dr. Bawazir with a raised hand. تفضل دكتور محمد.
شكرا. Thanks, Dr. Mishari. Thanks, Dr. Noor, for this excellent case. I really enjoyed the case. Excellent presentation, excellent management. Just for the junior colleagues, about 20 years ago, every zone 2 injury went to the OR, regardless of whether you had hard signs or soft signs, whatever. Every zone 2 injury went to the OR for exploration. But with the advancement in technology and the advancement in CT scan, if you have a good 4-vessel CT angio, what does 4-vessel mean? Means that you look at the internal carotid, external carotid, internal jugular, and the vertebrals. If you have a good 4-vessel CT angio, probably that rules out vascular injury. I'm not trying to criticize what you guys did. You guys did a great job. Another way of doing it, probably, if I was managing this patient, if I have a negative CT scan with no injuries to the vessels, with this amount of subcutaneous emphysema, maybe I'll take him to the OR and do a bronch and then an EGD to look at the esophagus and rule out injury to the airway and observe him. You guys lucky you discovered the brachial plexus injury intraoperatively, and I'm actually surprised the plastic surgeons went in to fix it acutely. What I know, usually they like to give it time and they manage it after a while, but that's good that they did that. I would like to know the rationale of fixing the brachial plexus injury acutely. Thank you.
You want me to answer to Thamr or you?
Yeah, go ahead.
For me, I think mainly it's because since it's acutely transected by a clean-cut injury and it was visibly in front of us, I think it would have been easier, more amenable for repair with better outcome rather than a delayed presentation, since we're already there in the OR. And I think if we delay it more, they might, as Dr. Thamr said, might fibrose, it might get retracted, and repair would be even more difficult. And since he's already in, we might as well make it a one-stop shop and try to fix as much as we can, since he was stable as well.
And maybe Dr. Muhammad, I would argue, we were not lucky to find it. We looked for it and we found it. So it's not, nothing here is luck. I guess the only thing is luck is that we were able to control this unnamed vein bleeding that we did not know where it's coming from. But to be honest, it was clearly transected. There was 2 pieces, and patient was completely hemodynamically stable. He was not acidotic. He was not coagulopathic, although the surgery took long. But ultimately, I think repairing it right then and there was probably the right thing to do personally. Probably they would delay it if we had elected not to operate and we figured out that he has a brachial plexus injury on a tertiary survey in the ICU next day or 2 days later, maybe they would have waited until everything is everything is stabilized before going in. But since we're in the OR and the 2 ends are sitting there next to each other, I really don't see why wouldn't they repair it acutely.
Shukran.
I think this is, we keep encountering these cases. If you allow me to give my comment, we keep encountering cases where you want not to explore, and then you stick to your guts and you explore, and then you discover that you did the right thing. There is something missing in the evidence that we're using. You have all these numbers where, Dr. Mshari was quoting in his paper a sensitivity of 28%. I mean, are we that desperate? Is the neck exploration this destructive to the patient and this harmful to the patient that we are willing to adopt a strategy that has a sensitivity of 28%? You wouldn't accept this for any other disease. A strategy of detecting injuries with a sensitivity of 28% is not acceptable in any other disease. I don't know why it's acceptable for us when, despite, we haven't done hundreds of neck explorations, but I cannot remember any neck exploration that had a complication from the neck exploration itself. So I'm not sure why are we really trying to avoid it. I can remember all the patients where the CT tried to fool us and then we ignored it and then we were right. There was a case with the nail gun to the neck where the CT angio was completely negative, and then the nail was actually inside the carotid. There was a case of a stab wound where it showed nothing and then the external carotid was transected completely. And then there is this case where it shows only subcutaneous air, and then you go in because you have good clinical judgment, and then you find all these injuries. And I think it's tremendous that we're still trying to find other modalities of treatment when neck exploration is just a very good and safe and practical solution. And as Dr. Tamer said, it helps you sleep at night. I'm just really, I want to do the no zone. I want to adopt the CT angio approach and then relax if it's negative. But I have been here only for 4 years, and it fooled me a lot. I have to say, this is my personal experience. CT angio can really fool you, and you want to go back to the report of that CT angio that the guys did at our hospital. The report was just subcutaneous air, no other finding. So I don't know. I want to do what the literature is telling me to do, but I'm afraid. Forgive me, but I'm really afraid.
Maybe the radiology department at your institution need to you have a discussion with them.
But it's not. I've encountered neck trauma cases at other institutions in Saudi Arabia. We need to be pragmatic. If the CT report, if the problem is the CT reporting across the kingdom, then I'm not willing, to make my patient suffer just because, it's not my problem. It's the CT reading. I think there is a clear defect here. Even the studies that are done outside, if you go over the slides that Dr. Mshari presented, these are not very reassuring numbers. I don't know what to say, but they're just not reassuring. I don't know if somebody has other comments to say, but that's what I feel personally.
I think this is the type of situation where we're looking at retrospective data, analysis of retrospective data, and maybe a randomized control trial, if it ever can be done, To me at least, I feel there's equipoise here where some of 50% are saying explore, 50% are saying observe, where we just randomize these types of patients who are to exploration versus observation, and we figure out what's the risk. I mean, it's not going to happen, but it's definitely something that I don't feel the evidence is there enough to convince me personally.
Great. Well, if we learned anything of this meeting is that neck injuries are really, fascinating to discuss after the fact, but really tenuous and hard when you're dealing with them acutely. And I guess, all kinds of discussions regarding, this neck, injuries are really informative. I would like to thank all the attendees, and I would like to thank our speakers. They've presented 2 very nice cases, and they generated very nice discussion. And we continue to learn and improve our approach to these cases. And, I just can't thank them enough. It's been a very nice meeting, 2 hours. آسف للإطالة، نعتذر على الإطالة عليكم. We're sorry for taking this much time, but I think it was a fruitful discussion. Thank you guys. I think with that we conclude our meeting. يعطيكم العافية.
Thank you so much.